Hello, welcome to Alterations of the Urinary System. So here's a little diagram. We're going to talk today about urinary elimination. We've already discussed bowel elimination a little bit, but the commonalities they have is that you can have altered motility, altered neuromuscular function, altered perfusion, altered patency, and these all result in altered volume of excretion, which has implications for our body fluid balance. So let's dive into some renal processes. We depend on the renal processes, so the kidneys, to regulate the amount of fluid in our body and what that fluid is composed of. We need the kidneys to eliminate metabolic wastes. We've talked previously about how the how the liver metabolizes waste and gets it out of the body, but the kidneys are the other main mechanism of metabolizing waste. The kidneys also play a part in the synthesis, release, and or activation of hormones. So specifically erythropoietin, which is needed for red blood cell production, renin. So remember we talked about the renin angiotensin aldosterone system and vitamin D. And remember that RAS system has a lot to do with the regulation of blood pressure. So the kidneys play a very important role. And then we have the urinary system. So the kidneys, you see there's two of them. They look like beans. They are located on your lower back on either side. We have two of them. And kidneys, they filter blood to remove waste, they regulate fluid and electrolytes, and they secrete hormones. Then we have the ureters, which transport that urine from kidneys to the bladder. And peristalsis comes into play here as well. So it's not just confined to to the digestive system. We need those little muscular waves to move urine out of the body. We have the urinary bladder, so that little balloon-like structure there at the bottom, and that is where urine is stored until micturition. So that is another name for urination, micturition. The urethra transports urine from the bladder to the outside of the body. So you can also see in this diagram that we have renal arteries and veins, and we also have the inferior vena cava, which extends behind the aorta and plays a huge role in kidney function. So each kidney gets a very rich blood supply. So a total of 20 to 25% of cardiac output. And that is necessary because we need constant filtration of that blood to get waste out of our system and also maintain fluid and electrolyte balance. So, what that pathway look like is the renal arteries arise directly from the abdominal aorta. So, after the aorta comes out of that heart, it extends down into the abdomen. And that happens in like the lumbar spine area, L1, L2 specifically. We have a longer right renal artery because it has to pass behind that inferior vena cava. Um, and each renal artery enters the kidney at what's called the hilum. And so that is this little concave area where the vessels, the nerves, and the ureters all connect. And then once inside, the renal artery branches off and distributes blood throughout the organs. So the inferior vena cava is the largest vein in the body, and it collects the deoxygenated blood from the kidneys and also any structures below the diaphragm, and it returns it to the right atrium of the heart. So it is the main way that um, there is venous return for the kidneys and the lower body structures. So After the kidney filters that blood, it needs to get back to the systemic circulation and it goes through the inferior vena cava. So it's really important that the inferior vena cava stays patent, it stays working, that the pressure is low so that the kidneys can have normal perfusion and what we call a glomerular filtration rate, which we'll talk about a little later in this lecture. The kidneys are surrounded by what's called a renal capsule, and that is just this very thick, tough connective tissue that surrounds the kidneys, and it's needed to protect the kidney from any trauma and infection. The kidney has a renal cortex that is the outer region of the kidney, and it's just below that renal capsule. And inside are the glomeruli, which are the little filtration units, the proximal and distal convoluted tubules. And this is the main site of where blood is filtered and where urine formation gets started. So that is the renal cortex is the main site of blood filtration. The renal medulla is also called the renal pyramid because it's the inner region. It gets arranged into pyramid type structures. Now, the renal medulla has the loops of Henle and the collecting ducts, and this is where urine gets concentrated. So, where water gets reabsorbed and electrolytes are kept in or tossed out. The renal pyramids are the cone-shaped section within the medulla, and the renal papilla, or papillae, whatever you want to call it, that is where urine is drained into the minor calyces. And I don't know if I'm saying that word correctly, but Calyces, or you can see on the diagram referring to that cut edge, Calx. And then that narrows to form the ureter, and that ureter's job is to carry the urine to the bladder. So the renal cortex is responsible for filtration and initial urine formation. The renal medulla concentrates urine. The renal pyramids drain urine into the callus. The renal columns support the vessels between the pyramids. The renal pelvis is where urine is collected for transport, and the hilum is where the vessels and the ureters enter and exit. So now that we have that kind of anatomical overview, urinary elimination is comprised of the urine production process, and then there's the elimination aspect. So this is part of maintaining an acid-base balance in addition to removing the metabolic waste and also controlling blood volume and pressure. So kidneys, once again, play a big role in maintaining blood pressure. So here's the beginning of urine production. Let's talk about a nephron. Just like a hepatocyte is the functional unit of the liver, a nephron is the functional unit of the kidney. And each kidney has about 1 million nephrons, and each one is responsible for forming urine. And the nephron consists of a glomerulus, so that is a network of capillaries, the Bowman's capsule, and the tubules, which are the proximal convoluted tubule, the PCT, the loop of Henle, and the distal convoluted tubule, also abbreviated as DCT, and then the collecting duct. So there's 1 million of those. Urine production, like I said, 20 to 25% of cardiac output goes to the kidney. Filters 1,000 mLs of blood per minute. And we have glomerular filtration. So you'll see that abbreviated as GFR, glomerular filtration rate. And that is when the blood pressure forces plasma into the Bowman's capsule, and that forms filtrate. And so this is dependent on adequate blood flow and blood pressure. If somebody's blood pressure is really low, that is one of the dangers of having really low blood pressure, is that your kidneys are not going to get perfused. Then we have the tubular reabsorption, which occurs mainly in the PCT, also the loop of Henle and the DCT and collecting duct. And this is where needed substances such as water, glucose, amino acid, and ions go back into the blood. So 99% of filtrate is reabsorbed back into the body. There is tubular secretion, DCT, and collecting duct. So additional wastes, like if we have excess potassium, for example, drugs, ammonia, these are secreted from the blood into the tubules. And that is where they kind of tinker with the acid-base balance and the electrolyte balance. That is the tubular secretion part. So finally, um, the final adjustment in urine concentration, it's really controlled by hormones. So remember, we have aldosterone, which will take up that sodium and keep it in the body and kick potassium out. And then we have antidiuretic hormones, which increases the reabsorption of water in the collecting ducts. And collecting ducts is where water is reabsorbed. And then the final urine that's produced goes through the renal papilla to the calyces, to the renal pelvis, the ureter, the bladder, then the urethra. So after it's gone through that, goes through the ureter to the bladder. The bladder fills up and it activates what's called stretch receptors. And that's when people get that whole like have to go sensation. So that signal stimulates contraction of what's called the detrusor skeletal muscle via parasympathetic cholinergic motor fibers. When the person's ready, they relax the internal and the external urethral sphincter, and that results in micturition. So here that is just phrased a different way, if you like it, kind of listed out like that, but it's a four-step process. We can look at urine characteristics and analysis of our patients pretty easily. The characteristics of urine, it should be very, very, very pale yellow. And it should be clear, it should be see-through. If urine is cloudy, that can indicate an infection. It has a slight ammonia odor. We generally produce between 750 to 200 mLs per day. On analysis, we look for color, clarity, we look at the pH, the specific gravity, protein, glucose, ketones, nitrites, leukocyte, esterase. So we really shouldn't have leukocyte esterase. Those are white blood cells. Nitrites, that can often be an indicator of a urinary tract infection. Probably not ketones, because remember, those are associated with when we have muscle breakdown, it's going to be excreted as ketones or fat breakdown, sorry. And then on a microscopic level, we look at crystals, casts, squamous cells, white and red blood cells, and bacteria. So we don't want those things in the urine. So we can have altered urinary elimination because of altered motility. And altered motility is talking about urine moving abnormally through the urinary tract. So normally it goes kidneys, ureters, bladder, urethra, by coordinated muscle contractions. and sphincter control. When that is impaired, the urine's going to flow really slowly, be obstructed, or just misdirection. And when that happens, obstruction can occur and urine just sits there. So, some types of obstructive um, altered motility can be kidney stones, strictures where, like a section is really, really narrow. Tumors can block flow, hydronephrosis, which we'll talk about a little later. Also, inflammation or infection, so UTI, cystitis, urethritis, um, swelling or pain impairs the smooth muscle contraction and emptying. And then also, people sometimes take medications which affect their urinary motility. So things like anticholinergics and opioids, they just relax that detrusor muscle too much. And so that leads to people retaining urine. And that is not great. So that can have big implications and be harmful to a patient. And then finally, post-surgically or as a result of trauma, specifically pelvic trauma or pelvic surgery, that can cause someone to temporarily or permanently lose bladder tone or coordination. Another cause is altered neuromuscular function. So, spinal cord injury, multiple sclerosis, anything that disrupts neural signals to the bladder and sphincters is going to be altered neuromuscular function, and it can lead to either retention, so a lot of urine that's just trapped in the bladder, or incontinence entirely. So, perfusion refers to the blood going through the kidneys um, and then supplying oxygen and nutrients while allowing the filtration of waste. So, when perfusion is altered, that means that there's not enough blood flow to the kidneys. And when the kidneys don't have enough blood flow, then filtration is not going to work very well. There can be tissue injury and reduced urine formation. So, glomerular filtration rate depends on steady blood flow and pressure. So about 90 to 120 mLs per minute in adults should be flowing through. Something called autoregulation makes it so that renal blood flow is pretty constant. Um, Even if there are fluctuations in the system. Then we have altered patency, which can be blockage of structures. So could be nephrolithiasis, like kidney stones, tumors, obstructive lesions, so like cancer, prostatic enlargement can do this, an inflammation or infection can do this. And sometimes it's a matter of something outside the urinary system compressing. And that could be pregnancy because when you have like an 8-pound baby sitting right on your bladder, that can cause altered patency and can definitely make urination uncomfortable. Here is a picture of different urinary tract obstructions. If you'd like to take a look, I'm not going to quiz you on every single one, but just so you have an idea of what could be going on. That is a picture of um, a hydronephrotic kidney, which we'll talk about here shortly. So, how does altered urinary elimination manifest? Well, you could have reduced urinary volume, altered urinary composition, could be very painful, especially kidney stones are extremely painful. Um, general malaise, fever, and GI symptoms because the bladder is really close to the stomach. So, a lot of times when something affects the bladder, it can also produce some abdominal symptoms as well. So, what do we use to diagnose and treat altered elimination issues? Well, macro and microscopic urinalysis, so just kind of like having it looked at with the naked eye, but also looked at under a microscope to really see the components. Imaging studies might be called for. Ultimately, we have to treat the underlying cause. So moving into our first exemplar, there's urolithiasis. So that's a fancy word for a kidney stone. So kidney stones form in the renal system, and then solid masses come out of the filtrate. So this can be caused by urinary stasis, when urinary levels of salts, organic or inorganic acids are really high. And there can be a risk of renal tubule obstruction. So, a couple of different types of pain associated with this. And I don't know, if any of you have had a kidney stone, I'm not sure. Maybe you know somebody who has. It's extremely, extremely painful. So you can have colic pain, which is when there is distension of the collecting system or the ureter, and it is very acute, but it's also intermittent, radiating and excruciating. So typically, if somebody has a kidney stone and it's kind of moving its way along, they might be in tears and not be able to function. But if it wiggles just a little bit, they might get relief. So it's very bizarre. And then there's non-colic pain, which comes from feeling the distension of renal calyces or pelvis. And that is a dull and deep pain with a varying intensity. So, how is urolithiasis diagnosed? Well, um, listening to the patients tell us about their pain and when it occurred. We also do imaging studies, so a renal ultrasound is preferred. Um, Laboratory analysis of the stone itself. So if you go to the ER and they find a stone on imaging, a lot of times they'll hand you a little, um, it's kind of like a sifter thing. I'm kind of losing my words for it right now, so that you can catch the stone when it passes, if it's something that, you can catch. Um, and that's important because especially if somebody has had multiple kidney stones, we want to find out what the kidney stone is made of. So most stones are going to be made of um, calcium oxalate, and also we have struvite stones. Those are fairly common as well. So, um, having that analyzed will tell us a lot about what we're dealing with and what could have caused it. There's also uric acid stones, and they are made of uric acid, as you might guess. So that is one that is very, very influenced by diet. So if somebody's eating a lot of organ meats, anchovies, shellfish, and red meat, they could be contributing to a uric acid kidney stone. Um, Gout is really associated with this because with gout, you already have a high level of uric acid in your body. And really, the treatment is generally supportive. So we would likely be giving someone some pain medication if they came to the ER, and then we would be probably sending them home with a script for something for pain. And um, usually that's enough. Like they can go home and pass it with one of those little screen things. If the kidney stone is over a certain size, then that kidney stone will have to be physically like removed by someone else. You have a stent placed. There are just different things that they can do. Um, they can't, increasing the fluid intake will always be a good idea, unless you have congestive heart failure. And it can show reduction of calculi size and removal of the surgical calculi. So, how do we want to prevent calcium oxalate stones? Well, for one, the thing is about kidney stones is there is a behavioral component, but there's also a genetic component to it as well. So, doing that stone analysis can tell us what is this stone made of. So if you have a calcium oxalate stone, then it's going to be important to check your diet. And that will likely mean cutting out those fun things like seafood. I don't know if anyone gets excited about anchovies. I get excited about red meat, so I'd be sad to cut that out. Um, but really, the things that are pretty high in calcium oxalate are spinach, rhubarb, nuts, beets, chocolate, and sweet potato. All those foods are high in calcium oxalate. So somebody with a kidney stone will need to be really careful about not taking those things in. Okay. Urinary incontinence. So, urinary incontinence, there's another name for it. It is called enuresis, and that is the inability to voluntarily prevent the discharge of urine. And I want to be clear, that is classified as after the developmental, as being, it would have to occur after um, it's expected that a child would be potty trained. So generally after age 5, we would call it urine enuresis when somebody can't control their urine. And this can be caused by impaired muscle contraction, altered neural transmission, hormonal stimulation, and mechanical factors. Um, we classify incontinence in a couple different ways. So there's stress incontinence. And we're not talking about stress like, oh, I've got to study for all my tests and get all my homework done. We mean mechanical stress, so physical stress on the body. So, what happens with stress incontinence is that the urethral sphincter um, or the pelvic floor muscles, it just can't resist the pressure from activities such as coughing, sneezing, laughing, lifting, or exercise. Um, and this can be caused by a weak pelvic floor. So, this does generally tend to happen to women more frequently, especially post childbirth and postmenopausal. Um, Pelvic surgery or trauma can often happen, and obesity is implicated as well. So that is incontinence that happens like when somebody, you tell a really funny joke and somebody says, I'm going to pee myself. This is so funny. And you just keep going. Well, that's stress incontinence. So just remember it's physical stress. It's not the mental stress that we're talking about when we say that. Then there is urge incontinence. So that is an overactive bladder. And that, what happens with that is a really strong urge to pee. And it's followed by an involuntary leak. And so this is overactivity of that detrusor muscle. This can occur in neurologic disorders such as stroke, Parkinson's disease, spinal cord injury. If somebody has an infection or stones, it can cause bladder irritations. And um, also, it could just be idiopathic detrusor overactivity. So nobody really knows why, but it just happens. We have overflow incontinence. That would be when somebody has exceeded the amount of urine that can be in their bladder. So when it's overfull, it can't empty completely. And that could be caused by things like an enlarged prostate, urethral strictures, a spinal cord injury, or diabetic neuropathy. Because with diabetics, with the neuropathy, you don't feel that stimulation as you normally would to go pee. So it makes it really easy to override the bladder capacity. And then we have functional incontinence, and that is completely, the causes of that have nothing to do with the urine. It's more like, does that person who was once independent became somewhat incapacitated and they don't have caregivers who are helping them. And when they really have to go and somebody can't take them quickly enough, they can't hold it in any longer. How is this diagnosed? Well, history of incontinence patterns and things that trigger it. Um, Physical exam, they might do specialized testing, such as a post-residual bladder volume, urodynamic testing, and endoscopic testing, so like a cystoscopy. Anytime you see that CYST, you think bladder, if it's in a word. So, what can really help with this is behavioral strategies. So, bladder training, and that is when somebody plans, a set amount in set times that they're going to go to the bathroom, and it might involve gradually making themselves wait a little bit longer and a little bit longer to go run into the bathroom. Pelvic floor strengthening, luckily, I think that more physical therapists are starting to wear that hat to help with pelvic floor problems. Um, Pharmacologic, patients can get anticholinergic medications and alpha adrenergic medications. And finally, if it's really bad, sometimes they will do surgery and that can relieve the mechanical obstruction. So let's move on to polycystic kidney disease. So PKD is a genetic disorder, and what happens is multiple fluid-filled cysts in the kidney are grown, and they just gradually get bigger. They distort kidney structure and they compress healthy tissue, and they just end up impairing renal function over time. So, how this kind of looks is that a genetic mutation in the PKD1 or PKD2 genes leads to defective proteins, which causes problem with the epithelial cell function and cell membrane signaling. And then the cells begin to proliferate, but in an abnormal way. And they're leaking fluid, they're secreting fluid into closed spaces. So cysts form when the new nephron tubules detach and continuing to enlarge independently. And when cysts grow, they compress any nephrons and blood vessels that are around, which reduces perfusion and causes ischemic injury. Here is my PKD patho continued. So you can have a genetic autosomal dominant or a genetic autosomal recessive PKD. It is acquired. With the dominant PKD, the kid gets one defective gene from one parent. And then this is the most common. And progressive cyst development and renal failure generally can follow people into adulthood. With the autosomal recessive, this occurs when there's two defective genes. So when each parent has the gene for this illness. And this can be fatal in early life. So, how does this clinically manifest when somebody has polycystic kidney disease? Well, their kidneys are going to be enlarged, have hypertension, flank pain, their electrolytes are going to be all out of whack. They can have kidney stones, urinary tract infections, and this also ends up involving the liver, the pancreatic cysts, the cardiac valvular disease, and cerebral aneurysm. So, the diagnostics for PKD, we want to get a good family history. We might want to do genetic testing. So if this is something that is concerning to parents, they might want to get genetic testing prior to conception. Physical exam, look for hypertension, and look for the presence of 3 kidney cysts on ultrasound. And you might even found cysts in a different location. Um, let's see, if they see greater than 3 kidney cysts, that is one of the big diagnostics for PKD. Labs will confirm if somebody is in renal failure. So once again, treatment is symptomatic, and we want to control the person's pain, treat any infection they have, get the blood pressure under control, and also promote renal function. And that can look like dialysis or even a renal transplant. To be honest with you, a lot of times PKD, it can be caught in the wound. It will generally show up on ultrasound. So the sooner it's recognized, the better. So glomerulopathies, these are disorders that directly affect the glomerulus. Glomerular disease has a very sudden onset of hypertension, edema, and an elevated BUN. We can have primary or secondary glomerulopathies. So when something is secondary, the glomerular injury occurs secondary to systemic disease that affects multiple organs. So basically, another way to say that is that the glomerulopathy is a whole other condition entirely. Um, let's see. Okay. Glomerulonephritis is an inflammation, and it is infectious. There are immunologic abnormalities, drugs, toxins, vascular disorders, systemic diseases, and viral causes as well. So I think somebody made a reflection that made me think about this a lot. We want to be careful about handling sharp objects in the hospital. Um, Especially with these patients. Um, let's see, where was I? So, what can happen is you form immune complexes in the circulation with those depositing in the glomerulus. And then the antibodies produce against the strep organism, and then they cross react with the glomerular endothelial cells. And that can be related to inadequately treated strep. That activates a whole complement cascade, and then all of these immune cells and mediators show up. So this can happen after an infection with strep. So somebody could just have a strep throat that they didn't get attention for, which is hard to imagine because strep is pretty miserable. And what happens is that the body wants to help out, so it produces antibodies, and the antibodies look enough, these antibody complexes look enough like something else it wants to attack that it will go and attack that. And then this ends up damaging um, the kidneys because those immune complexes get deposited in the circulation. So, what this can look like with acute glomerulonephritis is hematuria, so smoky brown tinged urine, red blood cell casts. So the casts are kind of like the little casings of red blood cells. And if we see red blood cell casts show up on a urinalysis, sometimes we don't even see the blood with our naked eye, but those casts can show up. And they can also give a clue as to where the problem is in the kidneys as well. So when you see casts, the problem tends to be further up. So somebody can have acute glomerulonephritis, very smoky brown tinged urine because of the blood in there, proteinuria, low serum albumin. So remember, albumin's that protein that keeps fluid in the body where it needs to be in the body. Um, Proteinuria might be is when protein is excreted in the urine. And because that albumin is not adequate, we will have fluid where it doesn't need to be, and that manifests as edema. And eventually, this will cause oliguria. And that is when ole means like not enough. The urine output is less than 30 mLs per hour or 400 mLs per day. So, renal failure, we can have renal insufficiency. We can have renal insufficiency, and that can be a short or a long process, and that can lead to renal failure. So, renal failure can be acute when kidneys fail. It can be sudden and rapidly progressive within hours. It's dramatic, but it is often reversible. So, it is an abrupt reduction in renal function, or it can be chronic. So, chronic means that it's slowly progressing to end stage renal failure over months or over years. And uremia is when we have elevated urea and creatinine levels, and this causes fatigue, anorexia, nausea, vomiting, diarrhea, weight loss, pruritus, so getting really itchy because those toxins are building up, edema, neurologic changes, and it's all just related to those wastes not being metabolized out. Now, the causes of renal failure, well, let me back up for a minute. So, acute renal failure is generally caused by things like dehydration, or when somebody is perhaps using a lot of times illicit drugs, or maybe they just took too many prescribed drugs, something that is super, we call it nephrotoxic when it's toxic to the kidneys. So kind of like a more sudden event causes like a sudden problem. So that's acute renal failure. Usually they can do dialysis to help with that acute problem, and a lot of times, especially if the patient is younger, like they will get better, their kidney will recover full function. So chronic is more your person who has um, several comorbidities, like they have really poorly managed diabetes, because that puts a bit huge burden on the kidneys to have to filter out excess sugar constantly. And eventually the kidneys are just going to get fed up and they're going to fail. But it takes years. It's not a sudden process. But the sad part of that is that usually by the time that they reach that point, like there's not much else to be done. And to be honest with you, when you see people with chronic renal failure, you see them at least I've seen them go to different providers and even kidney specialists. There's not much they'll really do once they're at a certain point. They just kind of say, well, let's just keep watching. And it's essentially like, let's just keep watching until you end up on dialysis or get a kidney transplant. But, organs are not easy to come by, so not everyone's going to get one. So the causes of renal failure. So we have pre-renal, intrarenal, and post-renal. And I'm going to just scroll to right here. When we talk about pre, intra, and post, kind of think about a person head to toe. And pre-renal would be, closer to the head. So it happens, that's the most common cause of acute renal failure. It happens kind of before you get to the kidneys. And mainly it's caused by impaired renal blood flow. Well, not mainly, it is. So sudden reduction of perfusion to the kidneys. And that is when, um, let's think of something. So say that somebody had a really severe infection and they became septic. And when they became septic, their blood pressure dropped really low. And so there's not enough pressure pushing blood to get the kidneys perfused. And that would cause acute renal failure because of a lack of perfusion. When there's a lack of perfusion, the kidneys aren't working, the glomeruli can't filter out. And so the glomerular filtration rate declines because there's a decrease in filtration. So intrarenal would be kind of like that middle zone. That is like damage directly to the kidneys. So acute tubular necrosis is the most common cause. We didn't really talk about that much. Post-ischemic, nephrotoxic injury, cortical necrosis, acute glomerular nephritis, like we just talked about, or vascular disease. So if you had a malignancy or something like that, like if you had kidney cancer. So that would be intrarenal acute renal failure. It's happening, direct damage to the renal parenchyma. Then we have post-renal acute renal failure. So that is something that could be caused by something below the kidneys. So, as crazy as it sounds, it could be something as simple as somebody has a urinary catheter and it just gets like kinked off for a really long time, and all that urine backs up, um, which doesn't allow filtration to take place. So that can occur with urinary tract obstructions of any kind. So even even like a kidney stone could do it, a bladder tumor, an enlarged prostate could cause post-renal acute renal failure. Chronic renal failure is most often caused by things like uncontrolled hypertension or poorly managed diabetes. So, dialysis or transplant is going to be the treatment. Chronic renal failure is classified as greater than 50% of those nephrons being lost, so like 500,000 nephrons. End-stage renal disease is a GFR of 0. Uremia is really severe. And there are just massive water electrolyte and acid base imbalances involved. And this can lead to multi-organ and multi-system failures. So, one of the most dangerous things is that the kidneys um, they're so important for regulating electrolytes, especially potassium. So the kidneys are not pushing potassium out. It's very easy for a patient with renal disease to be hyperkalemic. And I believe we discussed this before, but potassium is very much tied to the function of the heart. If we have too much of it, it can cause some fatal arrhythmias. So, a lot of treating patients with kidney disease, outside of them getting dialysis, is being very conscious of them not getting too much potassium. Um, it's where we have to be really careful about the medications we give them because they're not going to get rid of medications the same way that somebody with healthy kidneys would. It's very easy for um, drugs to build up. They will generally need something called renal dosing, which is they might need lower doses of medication, depending on the composition of the medication. Um, when somebody gets to this point, uremia is very severe. They're just essentially walking around poison constantly, and it causes metabolic acidosis. So earlier in the semester, we talked about how we can have respiratory acidosis when carbon dioxide builds up in the body. Renal failure can cause metabolic acidosis. So that is just a brief overview of alterations of the urinary system. I hope it was helpful. It's a pretty complex topic, so that is just a broad overview. Um, any questions, please reach out. Bye bye.